Okay, welcome everyone to October's instalment of the BOMSS Educational Journal Club this evening. I'm Sharif Awad, Consultant Bariatric Surgeon from Derby. I would like to introduce my co-chairs for the evening. So we have Jim Byrne, who's Consultant Bariatric Surgeon from Southampton and Council Member and Secretary of BOMSS. And delighted to also have Karen Coleman, who's NIHR Research Fellow in Bristol, and she's very kindly supported the Journal Club before taking part in one of the presentations. So the evening, this evening we're sponsored by Novo, so thank you very much for supporting the evening. And I'm delighted to introduce the Salford Bariatric MDT. So Bilal Al-Kafaf will be taking over as host of the evening, and he has a great team and some fantastic papers to present to you all. The evening will be recorded, as we always do. We'll make the recording available to BOMSS membership in due course. Please post your questions via the Q&A function down below. And we'll start presenting the IHP paper first, followed by a Q&A, and then the surgical paper afterwards. And just before we get going, just a reminder of the next educational webinar, which will be in 2 Wednesdays' time. So it's Wednesday, the 27th of October at 8 p.m. And we have the absolutely fantastic Peter Brennan, who's Consultant Max Fax, and he also sits on the Royal College of Surgeons Council. And I've asked Peter to talk about human factors and how we can make surgery safer and improve teamwork. So that should be an absolutely brilliant talk, and I hope you can all join us. But without further ado, I'll hand over to Bilal, Consultant Bariatric Surgeon in Salford. Thank you very much for hosting tonight, Bilal.
Thank you, Sharif, and thank you to BOMSS for inviting us to present at the Journal Club this evening. So we've got 2 papers, as is the usual way of doing the Journal Club. We're going to start off with Jodie Ellison and Chris Slater. As with most services, our services are run primarily by the AHPs, and now the glue that holds everything together. So Jodie is our CNS. She's very experienced, has been running the service for many, many years. And Chris is our specialist bariatric dietitian, also been with us for many years as well. So we're going to look at the first paper entitled, Does Intensive Multidisciplinary Intervention for Adults who elect for bariatric surgery improve post-operative weight loss? And this is a systematic review. So over to Chris and Jodie to start your presentation.
Good evening, everyone, and thank you for the opportunity. So yes, as Bilal said, we are looking at the paper, sorry, next slide, please. We're looking at the paper, Does Intensive Multidisciplinary Intervention for Adults who elect bariatric surgery improve post-operative weight loss, comorbidities and quality of life? A systematic review and meta-analysis that was authored in Australia at the Bond University Nutrition and Dietetic Research Group. So I'm Jodie, and Chris is presenting with me this evening, who is our specialist dietitian. Next slide, please. So a little bit of background about us. Our MDT consists of surgeons, bariatric physicians, anaesthetists, our psychologists, dietitians, and myself. In the UK, we have to adhere to strict criteria for people to be allowed NHS-funded bariatric surgery. So we follow the the NICE guidance. They have to complete a minimum of 12 months weight management, or a minimum of 6 months if their BMI is above 50. And during this time, sometimes it can be longer than this before they are referred on to our service. And they have to meet certain criteria, including losing 5% of their excess body fat. Next slide, please. So why did we choose to look at this paper? Chris and I, not so very long ago, had the opportunity to present at the Allied Healthcare Professional session at BOMSS, and we wanted to question this. Does losing that 5% excess weight loss have any bearing at all on post-operative outcomes? And we found that it did not. We wanted to see if there were further studies out there that could support this, And the meta-analysis and systematic data can be really useful, and also to pose further questions. So for example, what is the most effective MDT intervention post-operatively that supports people long-term with their weight loss and well-being?
So this paper was a systematic review and meta-analysis, and it had some quite robust methodology. It reported according to the PRISMA statement. It used the Cochrane risk of bias tool, and it estimated the effect of pooled outcomes using GRADE. They searched 6 different databases, and then they did a snowball search of Google Scholar and a search of the key papers as well, using various keywords that are on there. The primary outcome that they measured obviously was change in body weight. So it was either direct weight loss in kilos, or percentage total body weight loss, or excess body weight loss. And secondary outcomes that were measured included different comorbidities, side effects, mental health, and quality of life, and we'll go into them in a bit of detail later. So to be included in the review, the study had to be looking at a prospective comparison of pre, post, or pre and post intervention against a comparator group. The intervention had to be led by 3 or more members of the MDT. If it was pre-surgery, it had to be more than 2 weeks, and if it was after surgery, it had to be more than 3 months. They looked at any current bariatric technique used to treat obesity, and one of the exclusions was any old techniques. Other exclusion criteria included any interventions evaluating their usual care against the comparator, any interventions that were looking at maybe weight regain that were maybe 12 months or more post-surgery, and studies that compared types of procedures or different techniques or types of diet that people were following, or different individual types of exercise. So out of 6,000, almost 7,000 records from the different databases, they found 27 eligible publications reporting on 18 different studies. And the main reason for study exclusion was ineligible study design. So basically they were all conference abstracts. Majority of the participants, well, the 1,500 participants, 50-50 split between the comparator group and the interventions group. Most were from North America and Europe, and mostly reported on mixed bariatric surgeries, and only one study just looked at Roux-en-Y gastric bypass. Overall, the pre-op health was really quite poorly described, and only 11 studies reported on attendance after surgery, which ranged quite widely from 31% to 92%. So quite a variation there. In terms of the intervention characteristics, 4 studies looked at lifestyle and nutrition interventions that were mainly created by dietetics, run by dietetics or nutrition coaches. 4 interventions that looked at psychology, run by psychologists or behavioural counsellors, and then 10 interventions looked at exercise-focused support. 5 of the studies were done preoperatively, 10 were done postoperatively, and then 3 were done a mixture of pre and postoperatively. So the reported effects of pre and post MDT outcomes. Only 2 studies reported a significant difference in weight loss between the intervention group and the control group. Only 1 study reported significant improvement in any of the health-related quality of life outcomes, and no exercise-focused interventions reported significant difference for any of the outcomes. So they were the individual outcomes. So then they pooled them all, and they used all 18 studies to look at weight loss, because they all reported weight loss outcomes. And the type of intervention that they found was not really significantly different. So whether it was dietetics, psychology, or exercise focused didn't really make any difference. And there was no real significant difference in duration in the intervention, whether it was less than 6 months or more than 6 months, although This suggested to be better being more than 6 months, but it wasn't statistically significant. However, the timing of the intervention was significantly different. So it's maybe a little bit blurry, but you can see from the forest plot that the interventions that were done pre-operatively, if you look at the axis, tends to favour the control. So it showed that pre-op interventions actually reduce weight loss after surgery, but with only a very small effect. Post-operative interventions were found to increase weight loss with a large significant effect, and pre and post-operative interventions increase weight loss with a small significant effect. So basically, the best time to do these interventions is either pre or post, or just post. Looking now at the pooled effect of pre and post MDT intervention on health-related outcomes. So as you can see, the outcomes on the left-hand side there were reported on between 2 and 6 studies on that second column. And only anxiety, depression, quality of life, systolic blood pressure, and resting heart rate actually had a significant impact, but with a very low confidence in the evidence because of low sample sizes. So they concluded that there was no real significant difference between weight loss and metabolic outcomes, but intervention should really focus on the post-op phase. So we thought the strength of the study were that there was a broad multilingual search complemented by snowball searching. There was an appropriate use of grade to assess the confidence in the estimated effects. And it highlights really the lack of research into how effectively to use our MDTs. And it also highlights the surgeries, as we know, they just work no matter what intervention from the MDT and when it was done. And so we as an MDT need to show our worth in other ways, sorry, regardless of weight loss. So more work is needed then to determine who's most suitable to provide this MDT support, and it might vary depending on the patient as well.
So the limitations, the timing of MDT intervention criteria varied widely. In the preoperative stage from as little as 2 weeks to 12 months. In the postoperative stage, when that intervention started varied, and when it did start, it may last 3 months or up to 24 months. How or if the MDT worked collaboratively, the authors told us that this was poorly described over all the papers. The study did not declare how services were funded, so I wonder if this is a true representation of the general population, if there are funding barriers. No conclusions can be drawn about the relative importance of perioperative and postoperative care to a specific type of bariatric surgery. And the authors also cautioned us that although 18 unique intervention studies were included, their study aim wasn't to determine what the ideal provision of MDT support is. So as Chris pointed out to us in the results, only 4 studies actually investigated the impact of additional lifestyle and nutritional counselling. And again, only 4 investigated psychological interventions. Things we put great value on, and they were very small numbers and predominantly from Europe. Exercise focused interventions were largely conducted in the United States and not elsewhere. Many of the included studies had objectives related to specific healthcare outcomes, such as dietary change, suggesting really that randomized clinical trials are required to answer our question. Next slide. Okay, so conclusions. It is acknowledged that the MDT care prior to surgery is important, but this review lets us know that intensive MDT interventions to enhance post-operative weight loss, if delivered in the post-operative phase by any healthcare professional has better outcomes, but this is based on moderate evidence. The literature suggests also that when the post-operative interventions are delivered is interesting and suggests that this should be 6 months post-procedure. And the review conditionally recommends lifestyle and nutritional counselling or psychological interventions for improved mental health, quality of life, and at any preoperative or post-operative stage. And this was based on low to moderate evidence. So what now? Is weight loss a good measure for the impact of the MDT on our patients' health and well-being? We understand that weight loss and metabolic changes are a direct result of surgery. So when we think about addressing lifestyle and behavioural and psychological concerns that we hope will negate weight regain or allow bariatric surgery to be that meaningful tool lifelong, we really need to question our MDT intervention pathways, focus a little bit more on follow-up and perhaps reallocating some of our resources. So thinking more on that, we really need to challenge our commissioners on our pre-operative pathways, advocating perhaps a shorter time in weight management, and then maybe perhaps more collaborative working post-operatively, so they have the access to our centres, perhaps also locally as well. I'm pretty sure we will be at our time now, but I do think the latest semaglutide STEP trials are really interesting too, and will have a great impact on how we look at our MDT processes in the future. Thank you very much.
Thank you, Jodie. So Sharif, are you taking the questions?
Yeah, so Karen.
Sorry, I was on mute. I've now unmuted myself. I was speaking. Thank you so much, Chris and Jodie, for that really interesting paper. And I think it's a very topical systematic review that is interested to many of us as AHPs. There's been one question that's come through so far from Manya. And her question is, am I right in thinking that some of these results of not effective outcomes could be due to the small number of studies in the eligible literature pool?
Yeah, absolutely. I think any meta-analysis that looks at lots of papers that aren't really answering the question the paper's asking are going to throw this up, and randomised clinical trials for sure are needed to answer the question more in depth.
And again, I guess it just highlights the lack of consistency in reporting. So Bilal, you've done work with the gastro study looking at the variables that should be reported in gastric cancer trials. And it's just amazing that we've been doing bariatric surgery trials for decades and decades to prove efficacy. And yet there isn't an agreed study design or a formally agreed outcomes that should be reported by different investigators all over the world. It's a big task.
Yeah, I know Jane Blaisby's done a bit of work on this, in fact, and as part of the BIBAN sleeve study, one of the methodological projects or studies that was undertaken prior to the commencement of BIBAN sleeve was something called the BariACT core outcome set. So there is something there. But I
actually authored that study, so that there is definitely a core outcome set for bariatric surgery, and it is perhaps a problem that people aren't aware of it. And we're actually working with IFSO at the moment to try and agree a core registry set. So that work has actually been done, but getting it recognized and taken up is another challenge.
Okay, well, maybe one of the BOMSS webinars should be exactly on this, Karen. So you've volunteered yourself.
Yes, absolutely. Absolutely.
Another Wednesday evening with us. A question for either Jodie or Chris. So if I give you a blank canvas then, knowing what you know now, and especially in light of this paper, and you were to design the perfect bariatric surgery or weight loss surgery service, what role would the MDT play? And how long would you keep your patients in the pre-op preparation phase before you put them for an operation?
I think the MDT after surgery is looking to be the most important, isn't it? So one that includes multiple therapies that can be used differently for each patient. Every patient has different expectations and needs. I think we need to be flexible, giving them the core information that everybody expects. The pre-op intervention about the dietary changes and the lifestyle changes, etc., are really important as the core. But then I think the MDT intervention afterwards can be flexible and should be flexible depending on what that patient wants. And at the minute, it doesn't feel like that's available. They get one standard, and that standard is different wherever they have their operation, whether that's NHS private, north of England, south of England, wherever it is. It seems to be something different. So as Karen was saying, maybe some unity and that flexibility to provide what that patient needs would be the ideal.
Okay.
I think that variability even occurs within services. So our setup in Greater Manchester is that our tier 3 weight management is largely provided by private providers, and each private provider provides a different setup, a different intensity and quality of service. And that in and of itself can be a challenge and a problem as well. So it's not just about what happens between services, but within services as well.
Okay, so noted, and it's always good to learn from other units and what other units practice. I noticed in your opening slide, this is last question hopefully, in your opening slide, Jodie, you mentioned that you're still working to the sort of NHS England spec where BMI less than 50, you do 6 months in a tier 3, and over 50. So over 50, you do 6 months, and less than 50, you do a year. Now, that was mandated by NHS England, who no longer fund bariatric surgery. So is that something that you've carried on? Has it been imposed on you by commissioners? Have you not had the freedom to come up with your own sort of time limits?
So that's a really good question. And what we did was we set up a sharing best practice group for everybody who refers to our service, which I deliberately invited the commissioners to, so that eventually it would be a steering group for how we wish to shape the surgeries going forward. So at the moment, there is for me, that it was important that they all had a fair and equitable pathway to surgery. And we presented our data back to them to say that perhaps a shorter period, once it's identified that patients want to pursue bariatric surgery, and then get referred into us. And this is something that we're really pushing quite hard with now. And so I do hope we'll see that change. And I think as the challenge of obesity, the pandemic that was forgotten and now unforgotten, the allocated funding won't just be in prevention, but it will be in treatment as well. And I think then post-operatively, we should hopefully be able to work more collaboratively with all of those services so that they can have something in their local area, as well as coming into our centres, to hopefully support with more than just talking therapies, a lot more action as well.
So hub and spoke sort of model. So Mary O'Kane has put a message on the chat if you want to read it. It's for everybody about the author. So thank you, Mary, for that. And Jim Byrne has also put a message. I think he meant to put it to everybody, but it's only come to the host, to me and the panelists. So I'll just read it out. So Jim's comment on the paper. So thank you. It's a challenging area and lack of evidence is really clear, and we should our focus should be on those who struggle and do less well and have clear outcome measures and a cluster study. So I think that's a very wise take on quite a complicated topic. So we're moving on with time. Bilal, would you like to introduce the surgical paper?
Absolutely, thank you, Sharif. So the surgical paper will be presented by Barbara Ahmed, who is one of our senior bariatric and upper GI fellows, who's been essentially as part of the furniture now at Salford Royal. In fact, he was probably there when it was called Hope Hospital. He is just about finishing his training now, and he has also been supported by Mohammed Al Tarauni, who is our international upper GI fellow, who's come and joined us from Jordan for his upper GI and bariatric fellowship, and he'll be unfortunately departing and leaving us soon in the next few months. So over to you, Barbara.
So thank you very much, Bilal. I'd like to start off by thanking Novo Nordisk for sponsoring this evening. As Bilal mentioned, I'm Babar Ahmed, I'm one of the senior fellows at Salford Royal, and myself and Mohammed Al-Tarwani is my colleague, presenting in today's Journal Club the surgical paper. And the paper that we've chosen today is an original article that's been published in Obesity Surgery very recently in September 2021, which is a single center experience from France about the total gastrectomy with Roux-en-Y reconstruction for patients who have developed complex and chronic fistulae following a leak after a laparoscopic sleeve gastrectomy. Obesity Surgery is a well-reputed journal with an impact factor of 3.41 in 2019. And the authors in this paper have basically reviewed their experience in terms of managing of the chronic fistulae, and in particular surgical management, as this remains one of the major challenges and controversial treatment. So this is a retrospective analysis in which all the patients who had had a fistula following laparoscopic sleeve gastrectomy leak, who underwent total gastrectomy within a period of 6 years between 2013 to 2018, were all included. And they were followed up for 2 years. In total, there were 13 patients who were included in this time period who had filled up with the inclusion criteria. There were 3 of these 13 patients. There were 3 patients who had simple gastric fistulae, whereas 10 of them had complex fistulae, and of those 10, 2 had gastrosplenic fistulae, and 4 had gastropleural, and 4 had gastrobronchial fistulae. All these patients underwent total gastrectomy and open total gastrectomy, and those who had splenic fistulae also ended up having splenectomy or splenopartial pancreatectomy. Their outcomes in terms of their early complications were 38.5%, including 2 esophageal anastomotic leaks, which were managed on conservative method and did not require any further intervention, and they subsequently were all okay. The mean length of stay in these patients was 19 days, and they have reported no late complications after 2 years worth of follow-up. The mean BMI of these patients before sleeve gastrectomy was 36 kilogram per meter square, which in 2 years' time following total gastrectomy was 23.5 kilogram per meter square. And the authors have concluded then when there are other surgical options or other less mutilating options are not available, then total gastrectomy in dealing with such complex cases remains a viable and a valuable option. Now, analyzing this paper, this is a retrospective observational study, and this has been carried out over a period of 6 years between 2013 and 18 in a tertiary center in France. It's a single unit study, and it's actually a single surgeon study also. But this department does entertain patients not only of their own, but also from surrounding areas also. And as I've mentioned, that they have included patients who actually had total gastrectomy as part of their management of developed chronic fistulae, and they followed them up for 2 years. Now, introduction of this paper flows very well. I think it's very well written. I think the authors have successfully introduced the subject very well. They have identified and they've introduced the types of leaks which we experience based both on anatomy and in terms of time frame very well. They've talked about the management of both stable and unstable patients, where unstable patients requiring washouts and stable patients requiring conservative management with both radiological and endoscopic procedures. And they've introduced very well the various surgical options that are available in literature and are carried out in variety of centers, including total gastrectomy, very well. And they've stated their aims very, very clearly. In their methodology, as I've mentioned, this is a retrospective study. The reporting is again up to standards of strobe reporting. They have explained their settings. They have mentioned that it is a single center study, but they had included patients who were referred from the surrounding areas, including private hospitals. They had clear inclusion criteria. That all sleeve gastrectomy leak that had developed fistulae and had gone total gastrectomy are included in this patient in this paper. They've classified their sleeve gastrectomy leaks as per standard sleeve summit consensus, and that is acute, which present within a week's time, early, which is within 1 to 6 weeks, and late, which is between 7 to 12 weeks. And then they've classified their chronic fistulae, and this is where I'll come to in later on also. They've used a couple of classifications. One of the classification is that they've classified chronic fistulae as those who have failed conservative management over a period of 12 weeks. But the other classification that they've used is that is based on a paper, which is that they had failed multiple endoscopic and radiological treatments, but they haven't sort of defined as to what multiple actually means, and I'll come to that later on. And they've classified these fistulae, chronic fistulae, as either simple, which are gastrocutaneous or gastroabscess, or complex, which are gastro to another organ, which in their case was to spleen, pleura, and bronchus. They have declared the ethics, consent, and conflict of interest well. Further on in the methodology, they had a very standardized preoperative workup. They have followed a SNAP protocol, controlled sepsis in unstable patients laparoscopically with washouts, and in stable patients endoscopically with placement of pigtail drains to drain abscesses intraluminally, and radiological drains were required. They addressed nutrition through NJ feeding and had ensured that patients were had developed an albumin of 35 nanograms per liter before they were considered for a definitive treatment. They've defined anatomy with CT scans, upper GI CDs, and gastroscopies. And the mean time is 7 months between a sleeve gastrectomy and the total gastrectomy. They had a very standardized surgical approach. All cases were open, all cases were laparotomy, all cases had a hand-sewn double-layer esophageal anastomosis. All cases had same alimentary and BP limb lengths. Those who had splenic fistula involvement had either had splenectomy or splenopancreatectomy. All patients had commenced NJ feeding day 1, and then at day 7, when they've had a negative contrast study for a leak, they were commenced on oral nutrition, and they were followed up very stringently by the surgeons and the dietitians, at least for 2 years, but they'd suggested that they would follow them up for lifelong with vitamin supplementations. Coming on to their results, again, I think they've laid out the results very clearly. Some parts I'll come to in a minute, but again, they've explained that their sources of admissions, their admissions were, their own leaks were 3, whereas the people that they acquired were 10. They described how the 5 patients who were unstable had a laparoscopic washout, and 8 were managed on conservative basis. The tables are well laid out, well explainable. They have explained their intraoperative findings very, very clearly. and have documented their early and late complications well. Their outcomes are good. In addition to having a couple of anastomotic leaks, they haven't reported any pancreatic fistulae or any other major complications apart from abscesses that required radiological drainages. And the discussion in the paper, they have discussed in detail the pros and cons of various conservative approaches that they have employed, and they have compared them to what's available in the literature. And they have discussed the pros and cons of total gastrectomy with a fistulojejunectomies or Roux-en-Y gastric bypass in detail. They have explained their limitations, that this is a retrospective study with low number. And I suspect, I agree that the conclusion that they have drawn based on their data set seems appropriate, that the total gastrectomy is a viable option, although a very high risk procedure. Now, things that I've picked up which are weak, the weak parts or the limitations a bit more than just a retrospective part, and the fact that it's a low number. So one of the parts that I've picked up is in their methodology, is that one of the definitions of chronic fistulae, as I mentioned, was that this is based on a paper which they have quoted, which was an analysis in 2016, that if a chronic fistula is a fistula that has not healed after multiple radiological and endoscopic attempts. Now, when I dissect their patients, 9 patients of the 13 had only had one endoscopy, and it's not very clear as to how many endoscopic pigtail stents those patients had. And in particular, authors haven't explained what do they mean by multiple. They had 3 patients with simple fistulae, and I wonder, I don't know, I'm not sure how many of those 3 patients were actually in these 9 patients group, which may not have developed a chronic long-term fistula had there been more aggressive conservative treatment involved in those circumstances. The next step that I've picked up is that their PN is they have used PN in some patients, which they have mentioned in discussion part. They haven't mentioned about their funding status and their 30-day. They've done a 30-day post-op scan, which I couldn't understand the reason behind. In the results, one of the biggest things that I've picked up is that although they mentioned their mean between sleeve and total gastrectomy was 7 months, but there is a bit of a discrepancy that they've mentioned the range was 3 to 13 in the narrative, whereas in the table it comes down to about 2. Some patients that have been operated on in 2 months' time, which is something which is not very, very clear. Some patients, those who've had leaks, it's unclear as to whether they develop any strictures later on and how did they do 2 years afterwards. And finally, I think the more important part is that although they have discussed lots of papers, lots of options, but they have not discussed other important conservative treatment options, for example, intragastric stents and endosponge therapy, which are employed in certain centers. So in essence, it is a good paper. I think it does cover a very important topic of very feared complication and its management. And I think it does reflect that total gastrectomy is a viable option. But it'd be interesting to sort of see what our panel here thinks about various conservative options in addition to what the authors have employed, and also experience on other surgical treatment options apart from total gastrectomy. I look forward to hearing any further questions, please.
Thank you very much, Babur. That was a really clear presentation of this paper, which covers a really important subject. And I do think that a paper of this sort, particularly describing the development of complex fistula, it should almost be mandatory reading for any trainee, someone who's in year 4, 5, 6, who has seen their boss conduct, 4 or 5 sleeve gastrectomies in a day, doing a bit of training and thinks this is a straightforward operation. I think this, I'd be interested to know from the rest of the panel how I always talk about a sleeve leak as the Achilles heel of the operation, but I don't talk about total gastrectomy, and maybe I should. I think one of the difficulties with this paper, I wonder, is if it's covering quite a long period of time, 2013 through 2019, and I think one of the difficulties is the management has changed over that period of time, and the classification of leak is now much clearer. I think you described the classification very nicely, which is temporal, acute in the first few days, early up to 6 weeks, and the chronic ones that develop more later, and then splitting those into simple and complex. So I think your critiques and comments, I think, were all very well placed, but probably just reflect some temporal changes in our understanding of the process and how these things are managed. Is this something, how do you manage these in your hospital along those lines, Bilal? Classifying and dealing with sepsis? You work in Hope, where quite a few of us on the call, and I possibly wouldn't have had the pleasure of working in the management of fistula and abdominal sepsis is Hope is a leading centre.
Yeah, absolutely. You've hit the nail on the head. Much of what we do for sepsis has come from our colleagues and their involvement in national and international guidelines for the management of sepsis. We follow the acronym of SNAP. So manage your sepsis, get your nutrition sorted out, delineate your anatomy, and come up with a plan. So they're the 4 main points that we would use. I think Barbara's touched on a really important point, which is what are the other avenues that people have used, or that the authors have used before these fistulas have become chronic, regardless of how you define that. What I take from this is the situation had gotten so bad that the only possible outcome in their view was to do a total gastrectomy. So one of the benefits of doing bariatrics and upper GI cancer is that we've been able to utilize some of our experience from upper GI cancer into our bariatric practice. And certainly one of the things that we've been using for the last 5 or 6 years now within cancer has been the use of endosponge. And that that is an area and a topic that perhaps needs extensive discussion, but that's something that we've used, and we have used successfully. The other thing, one of the last sleeve leaks we've had was again a relatively simple leak, but rather than using TPN or using NJ feed, what we opted for was a laparoscopic jejunostomy, again something that we are comfortable doing because of our cancer practice. And where an endosponge has failed and the patient isn't septic, then at that point we can insert a feeding jejunostomy and send them home so that they're comfortable in the surroundings of their own home, and psychologically perhaps the stress isn't as great. Our experience of stenting is pretty minimal. We haven't traditionally used stent, and again that's probably because we don't use stenting to manage upper GI cancer leaks either, whereas other centres may. So I don't know what your views are on that and what other people's experiences have been.
So something I have used, and we've used in both cancer leaks and in a sleeve leak relatively recently, was pigtail stent that goes across the defect and allows internal drainage of the cavity. And that is, I think, that has been affected in, this is totally non-scientific and anecdotal. And basically, people know what we're saying. You put a pigtail stent across the defect, so you don't need to make the defect bigger as you would do to put a vacuum endosponge through, and it does seem to allow reasonable internal drainage of the cavity and be well tolerated. It mitigates the need for someone to be connected up to an endosponge device, and which needs changing every 72 hours or so.
Yeah,
That's
I agree.
That, I mean, if you tried stents, or from a practical perspective, how have you found the endosponge and getting the devices changed every 4
Yeah, absolutely. So it's every 3 or 4 days they need changing. It's technically challenging. You have to have everybody on board. So not everybody, I'm not going to be on call every time the sponge needs changing. We're not going to have an elective list, certainly during COVID. So you need all of your colleagues during during the on-call process to have bought into that. So the endosponge definitely comes with its own challenges. I think, again, we should probably be thinking about a more scientific approach to management of sleeve leak. We can look at some of our colleagues in Birmingham who've developed the esophagogastric anastomotic audit, and some of our colleagues over in the Netherlands who've developed the tentacle study looking at risk factors for leaks and how leaks are being managed. Wouldn't it be great if we could do something like that for sleeve leaks, given that sleeves are, the #1 performed operations anywhere on the face of the planet? Yeah.
Just interesting, from the data from this study, the mean BMI before the sleeve leak was 35. So
36, yeah. 36, yeah.
Low BMI patients.
Low BMI patients, yeah.
Should have been theoretically straightforward. And you just wonder whether the index surgeons or the index operation had the patient optimized. Have they stopped them smoking? Did they explain to them properly? Have they used an appropriate size bougie, or did they use a 34 bougie with a higher leak rate, etc.? Staple line reinforcement or not? And so there's so many factors that you can do. One comment that's come from the audience is that, and I'll read it out, very difficult reflection that a benign weight loss operation had such extreme sequelae due to a complication. True. Thankfully, at least in my experience and in our experience in the East Midlands, it is a very, very rare complication. And I think most of us will see one hopefully one sleeve leak every 3 to 5 years or so in our practice, as opposed to more regular than that. Javed Sultan posted a question, and perhaps we'll finish with this one, just to you, Babar. What was the median time in days from leak or fistula diagnosis to definitive total gastrectomy? Do you remember that from the paper?
So they haven't given median, they've given mean time, and the mean time is 7 months. With a range of 3 to 13 months. Now, there's a bit of a discrepancy in their table and their narrative. The narrative, they've said, is 3 to 13 months, but if you look at the table, although the mean is 7 months, but they've said plus minus 5.1, so it does take it to like 1.9 months to 12.1 months. So there is a tiny bit of discrepancy in their table, which I don't know whether the editor never picked up or the authors never picked up, basically, but I have mentioned that, and it's unclear as to which patient or which patients were actually in that early group, because it's not been mentioned. I think in the discussion they have talked about a patient that needed a reasonably urgent total gastrectomy because they were bleeding from spleen, and I think that's why they had to intervene quickly in those circumstances. But again, it's not very clear as to, in that range, who are the early ones, basically.
Well, thank you for that. We'll go back to Jim just with a final closing statement.
Just it's a comment, really. So I think leak is a really, really important subject, and I think that the literature is now becoming much more clear in terms of timing: acute, early, and late. And I think we need to be really thoughtful at any patient who's not making the right progress after a sleeve in the first 6 months. we have to consider that there may be a leak until we've proven otherwise. And detecting a leak can be challenging. I mean, there are three things that you need really to really be certain are probably the CT, a contrast study, and a gastroscopy. And the other thing is complex leaks, like large trees, grow from little trees, and a complex leak will invariably have started off as a simple leak, and the simple leaks are much simpler to treat. So thank you ever so much for choosing this paper and presenting it so beautifully, Barbara. Thank you.
Thank you. Thank you very much. Thank you.
Okay. And we are out of time. So can I take the opportunity to thank the team from Salford and Bilal for hosting tonight, Jim for co-chairing, Karen for co-chairing, and of course, all of you for joining us this evening. Please join us again in 2 weeks' time on the 27th, 8 p.m. For Peter Brennan's fantastic talk on human factors. Okay, thank you all very much and good night.
Thank you. Thank you.
Thank you.